I pass it over to Grace. Bruno, you're gonna put the slides, right? Yes. Thank you. Grace, over to you.
Thanks, Gus. Hi, everyone, and thanks for the opportunity to talk about some of the work of MRITE. We can go to the next slide. So just want to introduce ourselves a little bit. We are a 6-year USAID project. We can go to the next slide if possible. We started in July of 2020, and we were designed as a technical assistance project, really to address obstacles to high equitable immunization coverage. But soon after the project started, the US government became much more involved in COVID response, and almost all of our attention was diverted to COVID vaccination. It wasn't until about 2023 that we really moved back to focusing on our original mandate of strengthening routine immunization. And although we use the language of zero dose and under-immunized children now, because that's very much part of the global lexicon, we really, and we do support countries to find and immunize true zero dose under-immunized kids. Our approach is really focused on looking forward and doing what's needed to minimize the future numbers of zero dose and under-immunized children. Next slide. This slide shows 20 countries where we work, both for routine immunization and COVID. In about half the countries, we support both COVID and routine immunization. Next slide. I wanted to just show the framework for the project really briefly. I have some really dense slides, don't worry, I won't talk through the details. But we really wanted to highlight how in all of the countries we work, we really apply very tailored approaches to the work that we do. We look to identify the barriers both on the health system side as well as on the individual and community side. And we also really focus on that health worker and caregiver interaction, making sure that we're delivering quality, convenient, respectful services so that caregivers are encouraged to come back to complete the full schedule. I think this morning there were some comments about how we're not going to achieve what we want just by addressing the health system side. We completely agree. And at the same time, it's not all about, the knowledge and awareness of the importance of immunization. It's really those things working together. Next slide. So to put that slide in, in a little bit more practical terms, at the country level, we're really focusing on strengthening the key immunization, the key components of routine immunization. That's shown here along the bottom around improving planning and coordination, supply chain management, health worker capacity, demand generation, data systems, and data review. We use a variety of approaches, some relatively newer approaches to try to make improvements in these areas. So for example, in the area of health worker capacity, we've all done our share of trying to train health workers, but we know that knowledge is not really what improves performance. What we try and do is really use human-centered design to look at what are some of the obstacles that they face, the constraints that they face, and how can we address them so that they're motivated and ensure a positive interaction with the caregiver. Next slide. So I'm going to talk about some of our work in Mozambique, and we can go to the next slide. So here we use several different strategies to reach and monitor zero dose and immunized children. And I'll talk about a few of them in detail, but I also wanted to show in this slide some data around our results. So we started our work in the beginning of 2022, but like I said, at that point, we very quickly pivoted to a very intensive COVID focus. And at that time, there were also widespread stockouts in the country. So that tip that you see at the beginning of the slide is the first quarter of 2022, where the stockouts were a real problem. There's some improvement, but as you can see, a lot of the improvement happens later in the second half after we sort of return to our focus on routine immunization. And another thing I wanted to point out here is this is based on administrative data. And as you can see, coverage is 160%, 180% for DTP1, and 160% for DTP3. So just to highlight that one of the key questions we're always dealing with is how to make sure we manage, we provide better information on real coverage and have good denominators that health workers can use to gauge their performance. Next slide. So two key elements of our work in Mozambique are around community engagement and also innovative partnerships. So we know there are many, and it was mentioned this morning, many gender-related barriers to immunization. Women don't have money for transport to get to facilities. They have a lot of responsibilities. It's hard to take out half a day or a day to get to the facility. And sometimes services are not at convenient locations or convenient times. So we engage communities in order to try to address some of those problems, including community members in microplanning. And in some cases, we've had communities mobilize funding or identify a motorbike driver to help bring vaccinators to the community for services. We also work with influential people at the community level in order to raise awareness about the importance of vaccination and completing the whole immunization schedule. We also work with new partnerships, and this builds on our work around COVID vaccination, where we work with private companies at district level who can support transport, either to provide outreach services or sometimes also to pick up vaccines. So through that, we secured commitments from 3 companies who've signed formal agreements with the provincial health authorities, and they provide fuel and motorbikes in order to transport health workers for outreach services. Next slide. Also, as I said, at the beginning of our work, we knew that there were supply chain issues and there were vaccine stockouts. So we supported national and subnational quantification and forecasting of vaccine needs so that they could be more accurate to avert future stockouts, and also improve supply chain data quality, completeness, reporting, and use of that data. And as you see here, as a result of that, we have improved the percentage of facilities, and this is not just any stock, it's with the full all doses of all vaccines. Next slide. And then we can go one more after that. So I want to talk about a few of our interventions in DRC as well. And here, like in Mozambique, we use a multi-pronged approach, a set of interventions in order to reach zero-dose and under-immunized children. We're providing TA to help improve caregiver access by situating outreach services in more convenient, high-traffic locations. We're also leveraging partnerships, as I mentioned in Mozambique, to promote vaccination and also to provide support to actual tangible support for services. And I'll give more details there. We're also working with for-profit health facilities to add immunization services to their clients. Right now, we're working with 71 private health facilities and also monitoring their efforts. And then one other thing I wanted to mention, this is an effort that's led by 4 health zones to really very intensively track a cohort of children that are overdue for Penta 1. So this is just 32 kids. It seems like it's a tiny drop in the bucket in DRC, but this was really just a proof of concept of the role that community health workers and other health actors can play in consistently tracking and monitoring children who are late for vaccines. And as a result, 31 of the 32 kids are now fully vaccinated. And the health zones are trying to, again, this is fairly resource intensive, but the health zones are trying to see how they can scale up this effort. Next slide. So this shows DTP 1 and DTP 3, Penta 1 and 3 coverage in 2 provinces where we're working. I show a long time period before some of our intensive efforts begin in October of 2023. And as you can see, the coverage really is relatively flat, except they take a big dip in the middle there because health workers strike. Some of that strike is driven by late wages, so those are continuous problems in the health system around funding flows, paying health workers, etc. In October of 2023, we began more intensive efforts in these 10 health zones. And you can see in Okatanga, which is the green line, TTP1 and Penta 1 and Penta 3 coverage has gone up nicely. That improvement is a little more modest in Kasai Oriental. And we're continuing to work with staff on the project and with health officials to see, what are some other issues that we might not be addressing. We know at some point there were also stockouts here. We're not, maybe that's work that we or other partners also need to be working on. The next slide. So I really wanted to talk about some of the work that we're doing with new partners in DRC. So this, again, builds from some of the work under COVID, where we're working with local partners. These are little tiny local partners at a health zone level to support services. So and we think this is not only important because of the small bits of donations they might provide, which is, fuel for transport, or they provide space for meetings, but it really helps to broaden the base of support and a general awareness of immunization. So MRITE has facilitated 80 partnerships in these 4 provinces. And as I said, although the inputs are relatively small, we think they're really critical to delivering services. And MRITE coaches the health zone managers, so they're fully responsible for coordinating the partnerships and making sure the partners stay engaged. And we're really proud because in 2 of these provinces, Kasai Central and Lualaba, where we haven't worked for almost 2 years, we know there are many partnerships that are continuing, where partners continue to provide some of these in-kind and other contributions. Next slide. We're also doing some work on data completeness and quality, working to train health zone staff on reporting tools, on how to analyze and interpret data, and provide feedback to health areas. And we're also coaching data managers, health zone managers, and supporting health zone data reviews. So you see some improvements in the timeliness of data reporting. So I'll go to the next slide. And this, I wanted to talk a little bit, use this slide to sort of frame the last 2 interventions I want to talk about. So as a project, we're always looking, we were designed to, address entrenched obstacles. We're always looking to see what are the obstacles that we see, what are the root causes, and what more can we be doing to try to address those issues. We've seen that many common problems that we see in probably every country that we work in really can be traced back to a set of interlinkages around individual behaviors, health systems, and their processes, and funding constraints. So to address some of these root causes, we wanted to highlight these last 2 interventions that we're pursuing. So next slide. So in Jigawa State, in Nigeria, we're working to mobilize overall support and funding for immunization at the state and LGA level. So we know that LGA staff don't really have the skills, the confidence, or real understanding and awareness of the budget cycle in order to advocate for the funding they need for effective routine immunization services. And that microplans are often underfunded, they're not incorporated into the overall budget. So after conducting a financing landscape and a stakeholder mapping, we developed a capacity building plan together with the State Ministry of Health and the State Primary Healthcare Development Agency. And working into, say, in Kiawa LGAs, we held 3 workshops to analyze historical data, to develop budgets with strong justification of the needs and to advocate to the LGA chairman for funding. So ultimately, both LGA chairmen agreed to include a budget of 20 million naira, or about $12,500 for 2025 for routine immunization. So it might not seem like a lot, but previously there were no funds for routine immunization in any LGA budgets. And also because we included the State Ministry for Local Government Affairs in this workshop, they decided, and we're not 100% positive if they can just make this happen, but they decided that all LGAs in Jigawa should include a budget of 20 million naira for routine immunization in their budgets. So we'll continue to monitor that and hope those funds are forthcoming. Next slide. We're also doing work in Lagos and Edo states to institutionalize expanded hours for immunization. So there is evidence that expanded hours can improve coverage, but our goal here was, how can we make sure that this is not a project activity? This is something that will continue to last after the end of the project. So we use co-creation methods to work with stakeholders and caregivers to identify the barriers and the opportunities for expanding hours. You see, I'm almost at time. So maybe just to cut to the chase a little bit, through the co-creation workshops, 4 health facilities in Edo and 3 in Lagos agreed to expand hours. And in the process of the workshop, everyone got very excited. They have very ambitious plans. After several months, the 4 health facilities in Edo have really scaled back some of their ambitious plans, but they've all decided to include at least 1 extra session. Their ambitious plans were, some were going to offer it every day and Saturdays. But now at least they're adding 1 other day. And we're working to continue to monitor that. In Lagos, we've hit more of a bump where we learned about 80% of the people that were involved in the workshop were switched around and reassigned within about a month of the workshop. So there's sort of less commitment, and this is less of a priority for the new people in those positions. We're still trying to pursue this, but I know this is one of the issues that we face in all of our work, that people move. And we'll, as I said, we'll continue to look at the progress with this work. So just to wrap up the next slide with a few key takeaways. So reaching all children, we're really, again, we don't have some of the hard numbers that some of us would like to see, but we're quite sure that we need comprehensive approaches that address both supply side and demand side challenges. And they need to be very tailored. So I purposely showed, a range of interventions. We don't do the same thing in every single country. It depends on what the needs are. We also think it's very important to reach in order to reach all children, that the solutions be driven at peripheral levels, at lower levels, by health workers at the health facilities with the support of the districts or the LGAs. And I'm not sure what that means in terms of 6.0 policies, but we think that's a key principle we all need to try to get at somehow. We think we're showing some evidence on how engaging new partners, new types of partners can be effective, whether they're private companies or using new models to engage community partners, using new models to engage private companies. It's not a one-off thing. It's a continuous engagement that's locally led. There are long-term formal commitments, and that they can really help add support to resolve some key challenges. And then another thing we're finding in some countries, particularly where we're working on catch-up, is that it might be strategic to include catch-up as one of the routine immunization strategies, so that there's sort of more periodic catch-up to prevent buildup of large numbers of zero-dose and under-immunized kids. So that's it. Thank you very much.
Thanks a lot, Grace, for these. Sorry, Grace, can you please mute your microphone? Yeah, Thank you. Yeah. Thank you very much for this presentation. Very clear, very promising early results from the project. Let me go back here for the Q&A session from the chat here in the Zoom environment. There is one question related to, it's not a question, it's more kind of a suggestion and maybe some reflections from the MRITE projects about strengthening PHC links to reach those children. It's more suggestions to do that, to address specific target areas with entrenched bottlenecks and serious challenges. This is something you're learning, right, in the project, and can you talk a little bit about that? Because this has been.
I would say we are doing some of that in places like Nigeria and in Mozambique, where we have integrated. There is a framework in place for integrated service delivery. We're doing some of that around opportunities to identify missed opportunities for vaccination. I would say we're probably not doing that as much as we should be or could be in all of this is being recorded probably in all of the places where we're working.
I think we are all under the same challenge, Grace, and this is something we want to strengthen as an alliance. And I know there is a lot of effort, and we are doing a lot already, but I think all of us want to kind of increase our engagement in this integration, this PHC integration in the coming strategy. There is another point here, another question about the adjustments on the immunization schedule in Lagos and Edo. Curious to know how the decision was made in terms of purely the facilities decision, or is the regional management involved? How was that coordinated across levels?
So it was the facility staff and people at LGA level were involved, and they talked about whether it was feasible. And I think it was that it was together with the caregivers, so the administration, the health system side could really understand this could really be helpful. What could we be trying to do to make this happen? So as I said, in that workshop, everyone was super ambitious. But at the end, when they came to, we have to change people's schedules, we need extra people doing this and that, it sort of tempered it down, but still there was the commitment to at least including one other day.
Thank you. There was also a concern about the retention of trained workers after the project. There was, because you said like it's a comment that the scenario in Lagos unfortunate about retention, and even with the co-creating approach, still you got like retention issues. Like, do you have any kind of perspectives, insights on why it's so hard to retain workers? Is that I don't know, like is this like a
I mean, this is an issue, I think in all different types of programs, and for any time you have a project come in and train people, they will be moved for reasons that have nothing to do with immunization or with, skilled birth attendant or anything. That's just how the health system functions in many of these countries where we work. I think one of the things maybe, just sort of, this is a little bit aside from some of the work that we're doing. We do know that health worker planning and health worker management is not what it should be in many of the places where we work. That's one of the key issues. And to the extent that, Gavi and other donors, I think, can help improve the efficiency, effectiveness of that. I think that's important.
Then there's another question related to data quality improvements. What are the approaches of the project on these? And associated to that, another question is, how are you measuring success? Like what kind of indicators and measurement approach you're using?
So I think one of the key principles for us around data quality is data quality will improve if people think it's important, if people are using it, people at the facility, people at the district level. So, I think, again, this goes with the whole thing, one of the key takeaways, which, efforts need to be driven at local levels. and with very tailored solutions. So as part of all of our efforts to improve data, training to improve data, we also support use of data, review meetings, and helping them take action with this data. Oh, now we're finding that those communities or those wards are really underperforming. What can we be doing to improve that? In terms of indicators, I mean, we do have some indicators as part of the project around, completeness and timeliness of data that we measure.
Thank you. I don't think we have other questions, but I have a question myself on your recommendations in the end related to comprehensive approach. We know that every one of these interventions have risks in implementation, right? And we also know there are multiple barriers. If we implement a complex approach, there is a high risk that we're gonna hit into kind of some implementation bottlenecks. If we don't do that, we run the risk of not covering some of the barriers that are critical. I think it brings back to the discussion on the TOC that was discussed before by the Learning Hub initiative. Like, there is a need to kind of state all your assumptions, understand your problems, and design bundles of interventions that can answer to different project problems. At the same time, like, I think one of the things that we think about is, like, from a TOC perspective, like how complex and versus how simple it should be. Because we run in situations where, like, theories of change are very, very complex, multiple barriers, multiple interventions. It's very hard to kind of to understand what is contributing, to generalize to other similar settings. And when it's too simple, we run the risk of not kind of addressing the key barriers. So do you have any reflections in the MRITE project on, like, how comprehensive versus how simple you think, like, the interventions need to be to hit these kind of a sweet spots in which the key barriers are addressed, but it's still not running too many risks on implementation?
That's a very good question, and I might have better answers tomorrow. I would say my first reaction is maybe just to explain a little bit more. Before we do work in any country, we take an assessment of particularly in the areas where AID asks us to work, to see what are the barriers, what are the priorities we should be addressing. There are times for funding limitations. We see some barriers that we're not going to do any work in, because our budget doesn't allow us to do that. I would say yes, there's risk in implementing a complex set of interventions. There might be equal risk in focusing on just one simple intervention, because what if it doesn't work? What if there are other contextual and other barriers that come in? So, I mean, I don't think I have a good answer for you.
Great. I think it's something to put for thoughts for the next discussions as we continue with that. I realize we are again at time, Grace, and thank you very much for your contribution.